Good afternoon, everybody, and welcome to the second advocacy session of this conference. My name is Jana. I am a CML patient on treatment for 19 years, and for almost the same time, I'm involved in advocacy. This session, like the previous one, will deal with the impact of the COVID-19 pandemic, but this time on patient advocacy, and perhaps in more positive aspect of turning challenges into opportunities. We will have an introductory presentation followed by a discussion panel. Please let me introduce the speaker of the presentation and the moderator of the discussion panel, Lorna Warwick, whom you have met in the previous session. She's the CEO of Lymphoma Coalition, and her expertise for more than 20 years is especially in the field of communications and strategic planning. Therefore, she's the right person to lead us through organizational sustainability, good policy, and progress. Lorna, the floor is yours.
So thank you to CLL Advocates Network for asking me to speak about organizational sustainability. So I currently work for Lymphoma Coalition, which is a network similar to CLL Advocates Network of patient organizations with a focus on supporting those affected by lymphoma, including CLL. But to provide a bit of background, I have been working in the nonprofit sector for over 25 years and have experience with organizations of all shapes and sizes and focuses. And so this presentation is my personal best advice based on many years doing this type of work. So when we talk about sustainability, I think it's important to define what we mean. And it is simply the ability to maintain something at a certain level. So for us in nonprofit organizations, sustainability refers to how we will be able to ensure our work continues for whatever length of time we think is important. So sustainability is not about growth, but that is also important. It's maintaining at the current level. And in light of COVID-19, on top of sustainability, we also really need to think about resilience, or how we recover from any difficulties faced. And I think we can all agree that COVID disrupted our work and perhaps impacted our organizational focus as we had to shift to adapt to what was happening in the world, as well as impacting our personal lives. So I actually have a bit of data to present showing how COVID caused difficulties for patient organizations, just for a little background. And so the Global Cancer Coalitions Network, of which Lymphoma Coalition is a member, conducted 2 surveys with patient organizations in June and December of 2020 to look at the impact of COVID on cancer organizations. And there are 9 coalitions or networks that are part of GCCN, but you'll notice that 6 actually participated in these surveys. And the results of the surveys were published quite a bit in lots of different ways. And the results are available on the GCCN website if you're interested in looking at the full report. But I'm only going to highlight a couple of points regarding sustainability. And these results are actually only including the organizations that are part of the Lymphoma Coalition that have a blood cancer focus. So 84% of organizations fundraise or are raising funds from the general public. And COVID affected organizations' ability to raise funds the way they were used to doing, especially when local restrictions prevented face-to-face gatherings. So as a result, only 7% of organizations are confident they would be able to raise enough income, with the majority instead predicting their income would fall. And this group on average were anticipating losing about 40% of their revenue. And this is massive. So in the December survey, close to 70% of organizations said that this is exactly what happened. They lost this revenue. So as a result, 1 in 5 said their viability or sustainability was threatened. and almost half thought that they would have issues in the future. And mid and large size organizations were particularly affected by this. And when we asked about the people doing the work, all of the organizations work with volunteers. But the pandemic meant volunteering was down 70%. People couldn't get together. And that's how a lot of volunteering was based on face-to-face interactions. And it wasn't necessarily easy to pivot. At the same time, about 3 in 5 organizations had paid staff pre-pandemic. But the impact of the pandemic meant that they had to lay off or furlough about 20% of their staff. So organizations are coping with less money and fewer people doing the work. At the same time, almost all of the organizations had to change their programming. And this was both to address COVID itself, as well as moving into virtual programming where possible, often with additional unbudgeted expenses, I will add. And most organizations saw a significant increase in outreach from those affected by lymphomas, including CLL, as patients and their loved ones tried to understand how COVID impacted them individually. And so a lot of time was spent addressing these issues. But if you remember from the previous slides, while this was happening, they were dealing with reduced income and a reduced number of people to do the work. That meant that they couldn't do some of their other programs or services that they traditionally offered. So they had to pause or reduce to stretch their resources. And in most cases, these activities included advocacy, healthcare professional education, and research programs. So here we are, almost 2 years later, and the situation in the world is still really in flux. Some countries are fully open, others still face restrictions, but I think we are all hoping that there really is light at the end of the tunnel. But it's important to remember that patients with CLL have a continuing risk. And so while countrywide restrictions may be lifted or lifting, patients themselves may still be shielding to ensure they are adequately protected. So I hope these slides have helped you understand why resilience and sustainability are more important than ever in this changed world. But let's move on to some of my best advice for you. So first, know your purpose. Who are you as an organization? Why are you doing this work? What do you want to do, including what you don't want to do? Who do you want to reach? How will you know you are successful? Now, I don't mean only today, but in the future, thinking long term, you should have answers to each of these questions. Now, often this is done through a vision and mission statement, and these are those statements for the Lymphoma Coalition as an example for you. And you don't have to have something quite this formal, but you do need to agree amongst your leadership in your organization to your purpose as a group. And defining your purpose together will not only allow you to focus your work, but will ensure there is agreement of the key people in your organization, a rallying point everyone agrees is important. This is how you find other people who want to help you. They can see your big goal and say, I want to be part of that. Now, your purpose doesn't have to be static. It may shift over time, and you should revisit this periodically. Planning and prioritizing is more important than ever. And I know when we were all faced with COVID that the world became unpredictable. And even if you have plans, they changed. But I do think those that had a plan had a much easier time navigating through the chaos and change. They knew what needed to be done to reallocate resources, and they also know what they need to do now to get back on track. So why is this important? In the type of work we do, we are faced with many possible ways we can contribute and help, all of which sound important and can potentially help patients. But we are all limited to the same number of hours in the day and all have financial restrictions. So you have to know which of these issues are the ones you think you can address. If you try to do them all, you will spread yourself way too thin and you won't actually accomplish anything significant. So instead, focus on doing one thing or a small number of things really well and build your reputation and your organization. So planning takes your purpose to something tangible, goals and objectives of the actual programs you will be offering. These will be things you can measure to see if you're having impact. It will also help explain to others how they can help. When you call a repairman to come to your house and fix something, you have to tell them what needs to be done, agree on a time to do it, what the outcomes will be, and how much it will cost. If you don't do that, then the thing that you need to get fixed won't get fixed in an affordable and timely way. But the same applies to your work in your organization. Define what you need to do so you can tell you are making headway towards achieving your purpose. And if you don't have a plan, create one. If you do have one, now is probably a good time to review it. Plans are not static. They do need to change and need to be evaluated to make sure you're on the right path. But having a pathway forward that you all agree on will improve your chances for success. Now, collaboration. Your first collaboration is actually internally within your organization. You created your purpose and your plan together to ensure you were all good with those goals and what you're trying to accomplish, which is great. But I would also encourage you to document how you will work together and make sure it is circulated, including to new people who join. So doing this takes some of the politics and negative emotions that may appear amongst a group of very passionate people and allow you to focus more of your energy on the work at hand. So what do I mean by this? If there is a disagreement, who gets final say? If plans need to change, how will that happen? If someone makes a commitment for the organization that is not in the plan, how will this be handled? What behaviors will not be tolerated? How will you respond to conflicts of interest? If these types of things are documented, when you have issues, you can go back and refer to the documents, and it will make resolving the problems easier. Now, also remember, there are many other groups who may share one or two or all of your goals. So I encourage you to find others you can work with. Many hands make light work. We all have limited resources, both people, time, finances. So working together to maximize outputs for the greater good is important. Find others who are like-minded, though I will also encourage you to define how you will work together with external people as well. And you can learn a lot from other organizations who have done something similar, maybe in a different disease, in a different area of work, but reach out to others and don't be afraid to ask for help. That's the really big value in organizations like CLL and Lymphoma Coalition. Now, I think this speaks for itself. Digital is here to stay. So even in low resource countries, digital access to information and support continues to increase. And there was a rapid uptake during the pandemic. If this is not in your plan, it should be. Don't assume digital is going away if the pandemic fades into the background. Behaviors have changed. This is going to continue to be important. Please remember, with digital, we get into issues of privacy and data protection. So you should have policies about these kinds of things, or statements at least within your organization. And I know you may think I forgot about funding, but I didn't. I left it out on purpose. Because no matter how big or small an organization is, when I ask who has enough money to do all the work you want to do, no one ever raises your hand. Money is not a goal by itself. It is a means to achieving your goals. And I am a firm believer that your confidence and proven success will lead to people wanting to support your organization. Now, included in your plans would be a budget of how much you need to support your activities you want to do. And since you have already prioritized your plans, you will prioritize the budget. And so you raise money based on your goals and priorities. The focus then stays on what we're trying to accomplish, rather than saying, I just need more and more money. And as well, I just want to point out, and I know this lesson is hard, but don't be a reactive fundraiser. And what I mean by this is is taking any money that's offered to you, even if it's for a project that isn't in your plan. So really think about these opportunities that are presented to you before you say yes. Is it really helping your organization in the long term? Is it really addressing a patient need that you want to fill? If you do this unplanned project, will it mean you will have to spend more time and more money in the long term managing something that you didn't think was important in the first place? If the project is not something that makes sense for your organization, I encourage you instead to have a conversation with the people offering the money about what might actually be useful. You will find many times these conversations are productive and will actually result in something that is meaningful for everybody. And that's it for my quick advice in my 15 minutes. And if somebody has questions, please, you can reach out to me at this email address, and you can find out more about the coalition at that website. Thank you.
Thank you, Lorna, for your nice talk and for the valuable advice you have given us. And I would encourage the delegates to place their questions in the Q&A session. They will be dealt with at the end of this session. I think now I hand over to Lorna to take her place as a moderator of the discussion panel, which follows this presentation.
Thank you, Jana. So we are moving into an interactive live discussion with questions from the audience. So please post your questions, as Jana mentioned, into the question feature on this platform. And if you see a question that somebody else has entered that you would really like to hear answered, then please upvote that, and so we can prioritize the questions as they come in. So this session is on choosing your advocacy priorities based on evidence and resources. So you've already heard some of my opinions on this topic, so you know I think this is highly important, especially in light of COVID. And we at the Lymphoma Coalition are very data and information driven. So we use data from multiple sources, including our member organizations' feedback, our global patient survey on lymphomas and CLL, scientific papers, conversations with other people, and a lot of other resources to create not only a 5-year strategic plan, which happened when I became CEO, but we continue to use the same type of information to set our yearly goals. Now, when we're doing that, at the same point in time, we're evaluating, do we have the people and the monetary resources to support all the activities that we undertake? And do we have the right partners with us to make them happen? So yesterday, when Deborah and Michael presented the CLL Advocates Network survey of their patient organizations, this was fabulous news, right? Because it's a great way for the network not only to guide what was in this meeting, but for future planning to make sure that what they are doing is addressing your needs as the community. So this is good use of evidence-based priorities. Again, we all know that plans change because of COVID. And at Lymphoma Coalition, we had to change or delay some of our activities when COVID hit, just like everybody else. But in this session, we want to dig more into how this has impacted organizations and the lessons that people have learned, including, though, any remaining challenges that we might be facing. And we have 3 panelists joining us who will share their views and answer your questions. And so Jana and I have switched roles, and so I will facilitate this discussion, but Jana will be one of our panelists. And for this particular discussion, she'll focus more on her role with Diagnoza Leukemie, the organization that she founded in the Czech Republic after she was diagnosed. And as we all know, Jana has been a very strong advocate since, involved in many European and global initiatives, including she is on the steering committee of CLLAN. Now, joining Jana on the panel is Michael Rynne from Ireland, who you may have been introduced to in sessions yesterday. But for those that missed them, Michael's wife is a patient with CLL, and he is one of the founders of CLL Ireland, and he is also a member of the steering committee of CLL Advocates Network. And last, we have Gerard Masalago, who is a patient with a different type of blood cancer. And he is the chairperson of a new organization, the Blood Cancer Foundation of Tanzania. So we're excited for him to bring his perspective into this conversation. I will point out Gerard has been having some technical difficulties, so we really hope he'll be able to fully participate, but bear with us if we ask a question of him and it might take a bit to get a response. But welcome to all of our panelists. So as there is a big range of experience and the organizations represented have been around for varying lengths of time, to start, I think it would be helpful for our audience if you briefly introduced your organization by letting us know when your organization started and a bit about the types of services you have offered to patients. And Michael, why don't we start with you?
That's great, Lorna, and thanks for the opportunity to tell you a bit about CLL Ireland. As you said in the introduction, my wife Jana was diagnosed in 2011, and we realised very, very quickly that when we were trying to look for information, there was literally no information in Ireland about CLL, and we reached out to international organisations that we found on the internet, and we found that some of them were very, very well organised at providing information to their patients. We also realised that this information was going to be fairly valuable to us moving forward, as Jan maybe had to enter treatment. We're quite fortunate maybe in the timing of Jan's diagnosis in 2011, because the new novel therapies were only starting phase 1 trials. So as we gathered the information, and that led Jan to get onto a clinical trial, having to travel to another country, the UK, to get on the clinical trial, because again, Ireland had no access to clinical trials at the time for CLL. But to tell you how CLL Ireland started, was that while we were gathering information, we travelled to the UK to conferences that the CLL Support Association at the time were holding. And again, we saw how well organised these organisations were. And one thing that myself and Jan, when we were discussing, we said that if Jan gets back on her feet, gets her health back, we need to set something up similar in Ireland to provide the same information to patients. So the good news was that Jan entered a clinical trial in 2014 and did regain her health back. And it allowed us to, so it's always kind of maybe a bit controversial when someone asks CLL Ireland, when did you start? Because I feel we started as soon as the diagnosis and the information, but we became a registered charity in 2017. And from that, we're a volunteer-led, patient-led. We don't have any paid staff. So I think we do an awful lot we achieve a lot for considering the size of our organization. But I suppose that's probably to tell you where CLL Ireland formed. That if Jana wants to talk about her organisation, and I'll talk more about how COVID has impacted and all that later on.
Excellent. Yes, please, Jana, go ahead.
I'm very fond of international networking, because that's what was behind the empowerment of our organization, which was an informal group. In the days when I was diagnosed, patients didn't even have a legal right to access into their medical reports. So there was quite little we could do other than psychological support of each other. But then since 2005, when I got connected with similar patient support groups around Europe, I found what are the possibilities, and we formed a legal entity in 2006. But then 8 years later, we saw that our organization, although working on a voluntary basis and with no staff and basically nothing big except for the numbers of patients, but it became quite visible with good reputation, with some know-how and, let's say, connectivity with the medical society. So we wanted to open up the door for other patients with other blood cancers to let them in and utilize all this which was already built. And in 2014, we started with patients with CLL. And that was really a breakthrough change. Then we moved on to acute leukemias, MDS, and MPN. But now I would say that the CML patients as the traditional group, many of them being on treatment more than 20 years, and they form the core part of the organization. But you can imagine with CLL patients, that is what forms the big proportion of the organization. So it was definitely a good step forward.
Thank you for sharing, Jana. And Gerard, can you tell us a little bit about the start of the foundation in Tanzania?
Okay, thank you, Lorna. As I said in my introductory part, my name is Gerard. I was diagnosed with blood cancer, typically CML, in 2017. So I decided to summon the annual meeting with my fellow patients in 2019, and I declared my interest that maybe we could start organization. But by that time, it did not work out because many of the patients here in Tanzania are unaware. They lack awareness of the disease. Everybody that whom you can ask, he or she can tell you maybe about the blood cancer in general. He or she can't tell you about the CLL or the CML. So the problem here in Tanzania is awareness of the blood cancer disease in general. Now, why am I participating in this CLL conference while I belong to CML? I met my colleague who is the secretary of Blood Cancer Foundation of Tanzania, typically diagnosed with CLL, Mr. Mshana. So we decided to collaborate, that we can join together our hands to start the Blood Cancer Foundation of Tanzania, regardless of their types. So in 2020, last year, in December, we met together a few patients and some doctors or healthcare providers and discussed about the will to initiate the organization that we can reach many people and open doors to the community at large concerning the blood cancer disease. So fortunately, we were not registered. We started the journey to register the foundation. And I am happy to inform you that on the first day of this November, we succeeded to get the registration under the national level. So briefly, maybe I can tell you all how we started and where we are recently. We are new. We are trying to keep the pace as much as possible, and we are ready to learn it from you. Thank you.
Thanks, Gerard. And congratulations on your registration. That's a big achievement. So good for you for getting that done.
Thank you.
If we move a little bit into how COVID has affected local efforts, which is, of course, a big part of this discussion, maybe we can start with you, Jana. So what have you seen as the biggest impact for your organization?
Well, certainly we saw the barrier of the pandemic restrictions to meet in person, because it's not only about the knowledge, about the lectures given by the doctors, but also for patients meeting. And I think yesterday in the discussion, John said it very nicely, and I couldn't express it better, how important it is for patients when they meet during the coffee breaks and they can chat over coffee, and how beneficial it is for them, alongside with gaining the information from the clinicians. So this is a two-way benefit of these in-person conferences. And last year, it looked like we won't be able to perform any. At the end of the day, at the beginning of September, we're still, because in summer everything was looked like COVID-free, although it was just an illusion. But we were able to perform one conference. We usually have 3 per year in 3 major sites of university clinics where the majority of patients concentrate for treatment. So we choose these places. So we had one with quite a great participation, even of CLL patients. But that was it for the last year. And this year, the same. In the spring period, of course, the pandemic hit us severely. So we managed to get one conference in September and one in October, just in the time when the situation began to worsen. And currently, we are not doing very well as a country. So really, at least we managed these 2 opportunities. And from now on, again, the situation is not very positive, because still we have quite a number of people who are resistant to having vaccination. So this is something very frustrating for us. And we joined the CLL-AN global campaign about thanking those who have been vaccinated, as creating a safe environment for the vulnerable patients. But unfortunately, this message doesn't get to everyone right. And still in our country, there is a proportion of people who are not vaccinated at all, while the patients are heading towards their 3rd vaccine.
And so you made the decision not to switch to virtual, but continue to try to do face-to-face.
We try to continue with the face-to-face, because even from the clinicians, there is some resistance against, let's say, having virtual lessons, because the clinicians are like actors. They want to see the reaction of the audience, especially when it is patients. Now, here we are in a conference of patient advocates. That's slightly a different audience, but with the patients, it's preferred on both sides. It's preferred face-to-face. So we can only hope the situation will allow for the future continuation with this same model. But unfortunately, I didn't see much willingness to go for online lessons.
Okay. And Michael, what was your experience in Ireland?
Well, I suppose very, very similar to Jana. And Jana had mentioned, Jan, saying that the meeting of patients actually is probably the most important, and was the cornerstone of our advocacy, is that the patients could come and you could bring the international doctors in to speak at conferences and all. The patients for the first time were learning, because a lot of patients in Ireland wouldn't even know whether they're mutated or unmutated. They don't know the specifics about CLL. I was listening to Gerard and absolutely horrified to think that a patient doesn't even know what type of blood cancer they have. But, you know, we complain that they don't know their type of CLL they have. But the meeting of patients, because we had actually worked it up that we were having about 3 information days around the country in major cities around the country. We did find that patients coming and learning the clinical science of CLL, but they also the importance of meeting each other, but they also psychological support. We found that we ran surveys on them, and I was actually really surprised at this. And I know that in the advocacy arena that we all kind of know it now, the psychological support for CLL patients. But when they filled in the survey, it was a high percentage, like 80% wanted psychological support, which then they weren't being offered when they were being diagnosed. But so I suppose the meeting patients face to face, how we overcame that was that we set up a Facebook group, a private Facebook group. We had got a CLL Ireland Facebook, but that was kind of more information provider. So we have about 110 patients now that kind of connect with each other. That became very good during the campaign for vaccinations. And it's just amazing to think that you have to have a campaign to vaccinate vulnerable patients. But we found, like, to give you an idea of even the understanding of CLL in Ireland with healthcare providers, or we have an organisation here called the National Immunisation Advisory Committee, and they would make decisions on the vaccine rollout or who would get the vaccine rollout, and they had put CLL patients in cohort 7. So this was last December, so it was looking like CLL patients wouldn't be vaccinated till about June of 2021. So we had to join another organisation called IPOSI, which was an umbrella organisation, a platform for patients. And we put our logo to the letters that were going to NIAC and the government saying, "No, we need to move these vulnerable patients up the ladder." And we had a victory that we got patients up to cohort 3. But then suddenly when we looked at the fine print, we saw that it's only CLL patients that are going through treatment, and that the patients that were in watch and wait were back down in 7. So then we had to go back to them and say, well, actually, hang on, when you have CLL, it's a cancer of the immune system, and these patients need the vaccine now. So eventually, the patients, we did get another little victory in that they were starting to get the vaccine, but they were given the AstraZeneca. So in fact, I was actually fully vaccinated because I got Pfizer before my wife, Jana, that has a blood cancer. That's what ended up the situation. So, and even moving to now, we're on the 3rd primary. I won't call it the 3rd dose because it's the 3rd primary vaccination, and then patients are finding it difficult to access that here in Ireland. So I suppose during, as COVID hit, we became campaigners for all the different issues for patients, you know.
So I definitely saw a switch in what your organization does. I follow what Michael is doing, including on social media. And so you did start using your voice in a whole different way. And maybe you can speak a little bit too around the issue that you face with homeschooling.
Yeah, well, that was another one that because Jana is in a clinical trial in the UK, she's on the drug ibrutinib, which is a BTK inhibitor, and we saw very quickly the evidence was shown that CLL patients in general, the vaccine response is 70% less than the general population. So all CLL patients have a reduced response. But we found that patients that were on BTK inhibitors, most of them had a 0 antibody response to the vaccine. So it was said to us by the clinical trials team that if we have children that are going to school, they are going to bring the vaccine into the house. So we had to make a decision. So we have 4 children, 2 of them were of college age. So they were able to move out into a flat. We were fortunate enough to have that situation because they needed to live their lives. But we made a decision to keep the 2 teenage children home. And again, we had to lobby the government and Department of Education and the Department of Health to try and get online learning for the children, and they wouldn't give it. I never understand why they didn't give it. We shared all the international data with them. Department of Education was always saying that public health is telling them that schools are safe. Yes, they may be safe for the people that don't have vulnerabilities, but they're not safe for patients like Jan and other immune compromised patients. I know that Jan with the Irish Cancer Society did a podcast at one stage, and one of our immunologists was on it, and he would be one of the guys that would be giving the information on the TV about, and he admitted that when they give information to the general population, this information doesn't relate to patients like Jan. So we had the chief medical officer had said as well, had agreed with us, but with the Department of Education, they just would not budge on it. You know, that's.
Yeah, I admire you picking up and confronting some of those bigger issues, though, that were being faced by the vulnerable in Ireland, because it was quite a switch for you as an organization, but it was based on good advice. And I know that you had requested support just in terms of good information and evidence that was available. So when you were going back and approaching authorities, you had some credible data to back up what you were saying. So,
well, I think that's the big buzzword that we heard even at the other sessions is evidence-based advocacy. So the evidence was there. It wasn't that we just think that these patients are vulnerable. We know about the international data. What I will say about NIAC and what I didn't like about it is that they were using their data on looking at how many patients with a certain disease had died. Well, were the ones that were going to get the vaccine. But a lot of our patients, because of the information that they had, knew they were vulnerable. So they were locked up in their houses, which thankfully, you know, so to say, well, we'll only give it to the patients that had the most deaths, that group that had the most deaths, it's frightening, really, to be honest with you, you know?
Yeah. And Gerard, I don't know actually if COVID impacted the progress of you starting your organization, as it is fairly new, or any of the plans that you had in place, but maybe you can share some information on that, or if it wasn't a big impact, what your biggest challenge has been.
Okay, thank you. The COVID-19 did not avoid us maybe to initiate the foundation, so we kept on moving. But maybe to mention a few challenges at the patient level that they faced. Number one is fear and anxiety. So they fear what they have already, and over the fear on COVID-19. So fear over fear. Number two is economic challenges, especially those who are traveling the long distance from countryside. Here in Tanzania, we have one center for all types of, provided you have CLL or CML, we have just one center. So those who are coming from countryside are traveling a long distance. Sometimes they face economic challenges to visit the place. Number three is long appointment intervals. So whenever you attend maybe the given clinic, so you will be given a long appointment interval to meet your healthcare provider. The last but one is limited face-to-face time with healthcare providers, not able to share concerns sometimes. And the last, just to mention, is limited advocacy efforts. However, we have started the foundation to move on. That's all what I can say.
And so with your new foundation, when you're looking at all of these issues that you're facing, is there one in particular that you're going to start with, or do you have plans to combat different priorities at the same time?
The big issue that we have planned to start with is providing awareness to the community, where we can start at least our journey to conscientize the community around us. Then other issues may follow.
Excellent. I think that that's actually a great place to start when you mentioned that most patients are not even aware what disease they specifically have. So it seems like an excellent place for you to start. We do have a question about transitioning face-to-face and engaging people in digital meetings. And especially considering the fact if you're dealing with CLL, patients can be older. We know the average age of diagnosis is in the early 70s. So has anybody had any experience with that? So Michael, if you look at your Facebook group, for instance, does it really reflect the demographic of the patients who would be diagnosed?
Do you know what, Lorna, even when you go pre-COVID, when we had our information days, it probably, them information days, even though we would have up to 100 patients and their family members, wasn't the demographic, because that elderly, frail patients that maybe were living in the west of Ireland in different rural parts weren't coming up. So it's always been a difficult to reach out. We've had this conversation in advocacy over the years. I think that that Facebook page that you're talking about is actually very similar. A lot of the people on it have come to our information days. So when the email went out to invite them to join that group, we probably knew a lot of the patients, or we'd met them at certain stages over the years. I think that the only way that we can maybe reach them patients that are in the rural parts is to print booklets and literature. I don't know. I know that going back a few years, when we were having meetings in different parts of Ireland, once or twice we did radio ads, which would highlight CLL. And actually, I think that we did do this. Actually, some of the posters went into churches or into libraries, things like that. So I suppose we have to kind of be to reinvent. But that's different. Trying to connect with the patients. The only way that we can do it is maybe through other cancer charities that maybe these patients in these other parts of the country are connecting with. But it's evolving. You know, it's something that we do need always to work on in our space.
Yeah, I think it's important to remember we're in a time in history where even older populations have some experience with computers. And, you know, I always look at my parents as an example because they're in their 80s. But they do participate, for instance, not only in Facebook groups so they can check on what their grandkids are doing, but also, you know, participate in some activities via Zoom with meetings with friends or WhatsApp or Skype or lots of different things. So our aging population does not necessarily mean they won't engage virtually, as long as things are simple. And so, you know, as few buttons to press to get into the meeting as possible, as few buttons to press or difficulty asking questions. Sometimes people with arthritis, for instance, are going to have a hard time typing things in. So things they can do with a mouse is much easier as well. And this is an issue we have with my mom, who has hearing aids, is making sure all of the speakers are kind of at the same volume. So having good tech support for that. Otherwise, they can't hear properly when they're constantly adjusting hearing aids, if that is a problem for them. So there's things to consider, but don't rule them out as wanting to participate. And I will say this, and other panelists can chime in. I have signed up for things during the pandemic that I never participated in. And I had really good intentions when I signed up. But when you're sitting at home, things happen. You get emails that need to be answered because you're working at home. The dog needs to go out. You know, things just happen. And it often disrupts in a different way than it was when we were able to meet people face to face, right? So that doesn't mean you shouldn't be doing opportunities like this virtually. Just be aware that it opens up a different layer of reasons why people won't attend than you will see when you're face to face. And Jana, I don't know if you have anything to add to that.
Well, in my experience, it is often some conservative mind, because many of the CLL patients, they're not lacking digital literacy, but they are somehow not interested in Facebook activities. That's the problem, because they respond to emails, and even we had a general assembly remotely and they voted by email and it worked. But for Facebook groups, it's really more with the very young population in the CML like this. This is my experience. So I'm sending out newsletters via email to have information, but to let them join the Facebook groups, that's still a challenge. It's just a minority of people who see benefit of it. It's a prejudice.
Yeah. So if we move on a little bit, because we've spoken some about patient engagement and how we're trying to continue these activities. But when we look at sustainability, of course, funding those programs when they're different than what you have offered in the past might be problematic. So I'm just curious if either of you have experienced funding problems and what your results have been. So have you been able to find different ways of raising money to continue the organizations during this difficult time? And Jana, I'll start with you.
Well, I would say that since we are focused on what is the most important for the patients, we are realistic in our planning of activities. So far we have managed. And on the other hand, the widespread information, which goes not through the Facebook groups, but through the Facebook page. So this is only about the time and the energy, not that much about the financial resources. So to focus on awareness campaigns like this year, the September Blood Cancer Awareness Month has really been robust and has brought us a lot of new likes on the page, basically. So it's coming when I analyze who these people are and even messages. And so we have addressed a wider community, like parents of acute leukemia children, or patients who have been treated as in the childhood, pediatric patients who have grown up and now they just like the activities. So it's more of a moral support for those who take over these activities in the organization to carry on regardless of the situation, because we have to pull the organization away from all this to the future. That's our role.
Good. And Gerard, as a new organization, have you struggled with finding funding for your activities?
For the time being, Lorna, we are just using our pockets to facilitate what is being put in place for the time being. For instance, all the process of registration, we used our own pockets to make sure that we push the registration to be complete. But we are planning to summon a meeting that we can plan maybe for the funding activities, if any.
Good. I know it can be very challenging, and you happen to live in an area of the world where it's more so. So if there's any support or advice any of us can provide, please reach out. And we are almost out of time. So Michael, I'm actually going to give you the final word here. Do you have any best advice for our other patient advocates that are listening on how to move forward or what you've learned during COVID?
I suppose what I've learned is, like, going back to what I said about campaigning with blood cancer patients being invisible. We had a situation here where nurses were looking for a pay rise. The nurses can go down to the parliament and they can protest, but we're campaigning. But we're campaigning kind of just on the sidelines. It's very hard. So I would just tell the patient advocates to continue to campaign for patients. I think you're completely right about the digital age, that and we'll have to be inventive, and I suppose not to dismiss the elderly population on the use of digital. I was given an Alexa for my birthday, and I can just shout Alexa play, and it plays, you know. So that's, someday I'll say, Alexa, put me through to CLL Ireland, and it probably will, you know. So It's just for them to just keep going and just keep highlighting that we're not just advocating now for access to care for treatment of CLL, but it's access to vaccination, and now it's access to prophylactic treatment. So there's plenty of work to do. Don't leave the conference here and forget about the patients.
I think that's excellent advice. And it does remind us, right? Cancer did not stop during the pandemic. Diagnoses may be down, but that doesn't mean the cancer went away, as people are not getting diagnosed in a timely manner. People had their treatment interrupted. So there's lots for work for us to do to make sure our patients are getting back into the best care possible, and also making sure at the same time that we're keeping them safe from this pandemic and potentially future pandemics, that we don't forget the lessons that we've learned during this time. So I do want to thank each of our panelists for their participation and for sharing their insights with us today. We will soon have a 30-minute break, but before we do that, I would like to remind you that in approximately 1.5 hours or so, the winners of the patient session will be, the poster session, will be awarded. So if you haven't checked out the posters, you might want to do that during the break and vote for your 2 favorite posters. So you get 2 votes. Poster area is listed in the menu on the left-hand side of your screen in case you're not sure how to see the posters. And the votes can be submitted in the tab labeled Best Poster Voting. So please do that. I would also encourage you to make sure you don't miss the upcoming Hear from the Region session, where representatives from different countries will present their best practice examples of transforming challenges into opportunities in the context of the pandemic and its impact on patient organizations. And as well, later, there's a magic show. Who doesn't love a magic show? So make sure you join that as well for a little entertainment at the end of your Saturday. So please enjoy your break, and we will see you back in about 30 minutes for the next session.
Hello, everybody, and welcome to this session here from the regions. As most of you know, my name is Michael Rynne from the Steering Committee, and just to remind you, I was on sessions yesterday and the earlier on session with Lorna. I want to welcome you all to this important session here from the regions, but just to give you a bit of detail on how this session will run, as most participants may be aware, we had asked groups to submit an abstract ahead of the event to share best practice and their specific experience of service delivery during the pandemic. I'm delighted to introduce you to 4 representatives from the groups chosen to represent at the conference, and each of them will have 7 minutes to present their initiative. Following the 4 presentations, there will be 30 minutes questions and answers and discussion that nobody should miss. I want to remind you all, as always, you can submit questions in the questions and answers as we go, and that I will pick up these questions and put them to the panel in the question and answers discussion right after the presentation. So without further ado, it's now time to welcome the first presenter, Marianne, from Hematon from the Netherlands, which is an organization for patients with leukemia, lymphomas, and stem cell transplantations. So thank you, Marianne.
Thank you very much, Michael, and thank you for giving the opportunity to Hematon to tell a bit about what we did in the COVID time. I'll go to my next slide if I can. That doesn't work. Yep. Okay, the topics covered are given here, but I would like to go to the next one that's much easier. Hematon is an organization for all patients with hemato-oncological diseases and people with stem cell transplantations and their relatives, especially people after the age of 18. We are not dealing with children. Hematon was founded about 9 years ago after a merger of previous organizations that were dealing with the specific diseases. And since then, we have been growing continuously and dealing with all the diseases. At this moment, Hematon in the Netherlands has about 5,500 members, or supporters we call them. We have 160 volunteers who are quite active, and we have 4 part-time staff. Our motto is: we know, we share, we meet, and we represent. If we look at what we did in the COVID time, I think I've heard a lot of other people already doing similar things, but I would like to give a bit of a background what we did. In Hematon, we normally have 3 national meetings, one in the north, one in the middle, and one in the south of our relatively small country, where we have normally about 300 to 400 people each meeting, where we have in the morning a breakout with people who go to their normal disease, their own disease meeting, about 10 of them. And in the afternoon, we have general discussions. We also go into 10 groups about, let's say, work and cancer, about nutrition and all kinds of general subjects. We also are organized in regions, and in the regions we have people who meet with patients in smaller groups, quite often in hospitals or in walk-in clinics. These small meetings are quite important for the patient for their real contact. That wasn't possible, of course, anymore, so we switched over to webinars. And we were quite lucky that we had the hematologists who were prepared to give the talk that they normally would give in the morning in the general meetings, to give that online. And they did that quite well. And we had the possibility there also to give the possibility to answer questions via the chat. And that worked quite well. We had for each webinar now 200-300 people each time. That was quite normal. We had also webinars about the general subject that we would have done in the afternoon. So that was a real change, and we were lucky to have someone who is quite good in finding sponsors for these kind of activities that were new to us, and we wanted to do it properly. So we've done up till now, I think, 14 webinars, and we have still a few more to planned for the next months, because we don't see that big meetings will be going on. We had also a few regional meetings online, but that's more difficult. But people are getting to know how to do it. And I think that will also be continuing. We have, like I said, a lot of volunteers. We were all trained in using Teams as a system, and we now do nearly all our meetings that way, although we miss each other and want to change as soon as possible. That was the information giving. The information that for most people was really important is what does COVID do for me? We had a close contact with hematologists and with their national organization. And we have on our website frequent updates that were made together with these hematologists. And we had several parts. One was very general, and one was specific for each of the diseases that we're dealing with. So we had each time when our Prime Minister gave a press conference, we had thereafter an update. What does that mean for you? I think we are quite lucky in the Netherlands that we are involved in all the working groups of the hematologists. So we have the contact with the hematologists, and we could quite easily share, and they could share with us. We did also a special webinar about COVID, and that was attended by 1,200 participants. And also afterwards, you could look back at it, and that was done very frequently. Of course, a lot of questions were first about COVID, and then thereafter there were a lot of questions about vaccination. And we had at a certain moment had to help our telephone team to get more people in to answer all the questions. What we did with the hematologists, who we know quite well, is we negotiated with the Ministry of Health about our patients, and that we thought that they needed early access to vaccination. Of course, that takes a lot of discussions, but in the end, we came through together with the hematologist. And I think Hematon was one of the first patient organizations that really reached an agreement for our patients together with the hematologist. And that was for the first vaccination. And we recently, again, were successful to get the booster vaccination also for our patients. And I know that all the invitations for the booster have gone out to our patients. The next thing was a study. We've already heard today about several studies done about immune response for COVID vaccination in our groups of patients. There was a protocol made. We were asked to give input and have changed a few things. We've promoted the participation in this study because otherwise you can't do it, especially with a larger group of patients. And the first results were already used to have the arguments for the booster vaccination that is now approved. So that helped. And the first results were already published on our website, and the final results will also be published on our website. And we probably will also have a webinar about it once it's all known. I think that's what we did. And I think what we learned from is that the patient appreciates the regular updates, because as soon as there was something new on TV, they came to us. So we learned a lot from them. I think the online meetings, we think that in the future, there may be a combination of online and other meetings. We were quite surprised also for elderly patients who came into the meetings, often have their children helping them to participate. So I think it was a good experience. And what we really saw is the contact with the medical profession is essential in these times, because then you can really go quite fast in getting the information and having it to the patients. So that's what I would like to tell, and thank you for having me on behalf of Hematon.
Thank you, Mariana. That was really interesting presentation. And now we're going to move on to Leah from Flute of Light which is the Israeli Leukemie and Lymphoma Patient Organization.
Hello.
Sorry, you've the Canadian. So will we switch? We'll go to Peter. Yeah, okay. So sorry about that, Peter and Leah. So we're going to go to Peter from CLL Canada. CLL Canada is a disease-specific volunteer-led advocacy organization.
There we go. Sorry, my button wasn't letting me unmute. Can you hear me now? Okay, very good. All right, so I'm from CLL Canada, and thank you very much for the opportunity today. As well, I'd like to congratulate the organizers. I think this has been a terrific event so far, and I look forward to the next day and a half. And as well, Heymanton, I was so impressed with some of your numbers. I think you've done a tremendous job, and it gets me excited to know that there can be such outreach. So for our participation, what I'm going to speak about is our response to CLL Day, World CLL Day. And we took the tactic that with CLL and COVID being so stressful these days, we needed to get the message out. And we responded to the World CLL Day Challenge, and we put together a campaign for Canada. We're a small volunteer group, a volunteer board of directors. We have very few other volunteers. We did employ the help of a marketing firm who helped to guide us with some connections and some tactics. However, the messages that we presented were very much our own messages, because we found very quickly that although this was a firm chosen tactically because they've dealt with health groups before, they knew nothing about CLL. And of course, we know that this cancer is very different than many of the other cancers. So our campaign was drawn up with lots of different kinds of outreach attached. You can see in the graphic below, one of them was changing our website. You can see we used the effects of the CLL, the World CLL Day campaign, the umbrella, the immunity community hashtag were all important parts of our contribution on a national scale. And but we both used on our Twitter feed, we used a lot of those graphics, and we proceeded to rotate those graphics through on World CLL Day. And there was also a press release that went out to all media, and we'll speak about that in a little bit as well. The CLL directorship, we identified key spokesmen in each province who could speak to the campaign. Canada, as I'm sure you all know, is a large country. It's 3,000 miles across, 5,000 kilometers across. And news is always local. News is always local. You know, if you're a spokesman in one of our provinces, or if you're carrying a story as media in one of your provinces, we'd really like a local person to talk about that story. As good a speaker as Deborah is, or Raymond, our president is, it's a great advantage to have a local speaking to the topic in a community. Our media firm we used, Argyle, they designed an umbrella and a CLL banded mask, which was sent to media outlets and influencers. I want to talk about the influencers for a second, because influencers, as you may know, are somewhat new to the scene of marketing. And an influencer is someone who has a tremendous following within a certain topic. So we reached out to health influencers, and these are people who may have, I'm sorry, I'm guessing the number, I just don't have it off the top of my head, but 10,000 followers on their Instagram. So if you're following an influencer, you're liking what they say. So this is a group who are willing to share a tactic or something online and are willing to listen when an influencer talks. This is different than a random, say, a TV show when you get an interview and it's sort of spam to everyone listening. This is when you have an influencer talking, they're talking to someone who has an interest in health. And what we've asked the media and the influencers to do is to spread that message about immunity protects our community. We spread the message about social distancing, of course, and wearing masks. And the fact that we can walk down the street and someone would not know that we have a blood cancer. It's a little different than some other diseases, but those people are out there. We're out there in the community, and you would never know we're there. So please be kind and please protect yourself for us. In Canada, we're a little more fortunate than many countries. We have 74% of our population fully vaccinated and 84% of those 12 years old and older. So we're doing okay. Unfortunately, though, there are still a lot of naysayers to the vaccine, and somehow they need to be reached. In fact, we have a few of our provinces who they won't be mandating vaccine in the hospitals for hospital workers. And one of the key reasons is that they would be so short-staffed, they wouldn't be able to provide good care. So we have our challenges still, even though there are good numbers. The campaign was for the one day, and the campaign also led through the month being, Blood Cancer Awareness Month. However, we really concentrated on the one day. So the results of the campaign, this is one of our influencers here with their umbrella and with their mask. And the influencers wrote wonderful tributes to what CLL is about and very clear messages to their readership, which was fantastic. Campaign outcomes, a total audience reach of 2.2 million exposed to the CLL Canada message, and 633 media views of the press release. The media views of the press release, I think, are the most encouraging because for the most part, these are folks who had no idea what CLL is and no idea of what who we are, what we're trying to accomplish. So just to get in their minds for this first campaign of what we assume will be a forever campaign. And 3 mainstream prime interviews, Toronto, Calgary, Saskatchewan. So Calgary and Saskatchewan are in the extreme west. Calgary's in the extreme west of the country. Saskatchewan's in the middle. Toronto's in the east. So we were a little bit across the country. It would be wonderful if we had 3 times that number of pickups. But again, your first time you do a campaign is sort of a benchmark for the future. So we were happy with those. And then the press release itself made appearances in 14 different media. Social media reach, primarily with Twitter, was about 95,800. Again, using the community immunity hashtag. We had new followers as well, and we followed new people who saw what we were doing and who we are. We initiated a Twitter feed probably about 4 months before this campaign. We had those 3 well-recognized health influencers help us out. Now, lessons learned. It is a big country, and we found that we probably don't have the depth of knowledge of who would be good representatives across the country. So that's something we have to look at in the future, see if we can find more spokespersons to represent different geographies. We have a small population, of course, for the geography, so that is always going to be a challenge for us. We're going to place more emphasis on just the whole blood cancer month. This was the day, and we'll continue with the day, but we'll talk about the month as well. And just one little piece, it would be nice if those masks were usable, but frankly, they weren't usable. they had gaps and nobody could wear them and feel safe. So the promotional company felt a little embarrassed about that, to be honest, as well. But next time, if that kind of a case, we'll know better. And we really want to help people stay safe, so we have to go through the motions ourselves. And that's the very basics of our campaign.
That's great, Peter, to hear all about that. And just looking at the map of Ireland, or the map of Canada compared to Ireland, and when you're talking about 5,000 kilometers one way and 3,000. But anyway, we're moving on now. We'll move to Leah, and my apologies earlier on, Leah. Leah is from the Flute of Light, which is the Israeli Leukemia and Lymphoma Patient Organization.
Hi, everybody. I also come from a very big country, as you know. And I will speak about what we did. We did versatile things. As the pandemic fell on our heads unexpectedly, almost a couple of years ago, it was a major shock to the general population, but to CLL patients more so. I don't know if I speak for every CLL patient, but for many years before, I felt I was lucky. It was a good cancer, and we were in the good side of the cancer community. And now, all of a sudden, we are the weakest ones, and we have the most problems. Quite at the start, it became clear that the CLL patients are at higher risk to develop major sickness and high risk for death. The medical world was very hesitant, divided, issuing quite bewildering information and instructions. As about the CLL patients, it was more extreme. Patients had unmet questions. What are really the risks? How different are we compared to the general population, or even to other high-risk people? How will our medical treatments continue? And more. As the vaccination were applied, it turned out that a large group did not develop antibodies at all. And that was quite a big shock to a lot of people. Very few antibodies the others had. So the doctors insisted that we continue to act unvaccinated. And that was very difficult also for us and for our families, which were glad that there was the vaccination. Finally, they could come back to life, which was not the case. The lockdowns challenged the continuation of the administration of treatments. First, because of the difficulty to reach hospitals and clinics for some people who couldn't have their own cars, because public transportation was absent at times, at long times, or dangerous for CLL patients. Almost immediately, our organization, Khalila Or, has stepped in. In the information area, we issued patients' education and informative activities, such as numerous Zoom meetings, frequent medical conferences with the participation of prominent medical and supportive experts. Naturally, in the COVID-19 area, we had to switch all our activities to virtual, and we held many Zoom and Facebook Live meetings on various medical, but also non-medical topics like nutrition, psychological support, exercise at home, art activities like writing and photography, and more. During the lockdown periods, we held a weekly webinar to keep our members in contact and busy. Addressing the transportation issues, we provided transportation services with taxis to patients to get from home to the hospital and back, as it was too risky for them to use public transportation, which was also reduced. We gave more than 1,500 rides for more than 300 patients all over the country. We were caring for CLL patients' personal mental state and arousing fears due to the whole situation and the isolation. We accelerated the personal support because together it's easier with our Circles program, peer-to-peer support mentoring, connecting patients, as can be seen in our poster in this conference. Using extensive social media to enhance our activities, but kept in close touch with our members. We have about 4,000 members in our media activities. We kept in close touch and collaboration with the Israeli Hematologists Union, and particularly with hematologists at hematologic hospital wards, and with governmental authorities when needed. In general, we had an open heart and ear to our members, their families, and carers, and I can witness that many of them call and speak. Sometimes just they want to speak. Sometimes they have questions, but many of them just need somebody to speak and hear. To summarize, we took upon our organization to do the best possible to enable and make it easier for CLLers to go through this difficult, bewildering, and unexpected pandemic. Thank you all.
Thank you, Leah, for that very interesting presentation to hear about. We hear about Israel a lot in the news because you're kind of leading the way with vaccination and on the booster vaccination. So, but okay, just to move on to our fourth speaker, in case you don't know him, last but not least, we have Nick York, who is chair of CLAN, and he is also Patient Advocacy Healthcare Liaison Officer in Leukemia Care. Leukemia Care is a national UK support charity dedicated to support anyone affected by blood cancer. And thank you, Nick.
Hi, everyone. I'm not able to see my slides. Aha, that's a good reason, yeah? Thank you, Michael. And really fascinating listening to everybody's initiatives. I think one thing that jumped out at me is my working title is Patient Advocacy Healthcare Liaison Officer, PALO for short. But that is because my primary role is actually focusing on liaison with our healthcare workers, the clinical community, and our collaborations. And I think what was coming out of some of definitely Leah's and Marianne's talk there, the collaboration with the clinical community has been key for delivery of the initiatives. And I think that's something that reflects in what I want to share. I'm sharing a very similar presentation to yours, Marianne, and it's probably from the perspective of a larger organization, or an organization maybe you've got a broad remit, but so if we were looking at the topic, I'm just going to focus on two of the elements rather than the broader aspect of all digital change. But yeah, we've had to make a broader digital change, but just from an emphasis, just to put things where Leukemia Care is the largest leukemia-specific charity in the UK, and our primary focus is on CLL, CML, AML, ALL, the main leukemias, and all of the rarer subtypes. And then we also focus very closely on MPN and MDS. So we're quite a broad and large group of patients that we're already in contact with, and a large audience and a large group of patients to maintain contact with. And I think the other thing to put in place here is maybe a slightly different perspective. We're not a patient-led organisation, although I am a CLL patient and I come from a long background in advocacy and patient advocacy and patient-led advocacy. We are an organisation with quite a human resource and dedicated teams of regional care coordinators, advocates, and a communications team, which has helped us probably facilitate things a lot quicker than people had to. But basically, we had to react. I'm not sure if everyone's aware, in the UK, March 2020 was when things started to peak in the UK, and the clinically extremely vulnerable, as the group were called in the beginning, sort of one group of vulnerable that included the immune compromised, were advised to shield. And basically shielding was, we were confined to quarters at home, isolating. And if you were living with other people who were still out in the community, it was before lockdown, it was quite a troubling time for patients. At that same time, then we had the first of the lockdowns, and we had 3 then compulsory lockdowns during the peaks. But shielding remained in place all the way through that. So basically, that's, you know, just to explain from the UK point of view, clinically extremely vulnerable patients were shielding effectively right the way through till June. And we know now, obviously, as CLL patients, many of us still are. So just to discuss things, at that point, in March, Leukemia Care cancelled all person events and support groups. And to put things in perspective, we had a UK network of over 30 different local support groups providing peer-to-peer support. Those were in the process, those were being run and managed by the regional care coordinators and teams. And we probably hosting between 10 and 12 regional and national in-person events a year. So that gives you a scale. Challenges was right at that moment, there was no warning, instant lockdown, patients to shield, followed by a total lockdown. That left our entire support network, where we had quite a heavy involvement in in-person support, rendered useless from that point of view. And with the uncertainties that were happening at the moment, everybody's touched on that, constant moving picture, clinical conflicting guidance and information coming from government not connecting with the clinical community, healthcare professionals and care resources being redeployed, and then patients not having access to their doctors and clinicians to be able to gain insights of what they should be doing, what they shouldn't be doing. Everyone knows the picture. The first thing we really needed to do was to actually understand the picture on the ground, what's happening to patients, because shielding meant you were confined to quarters. That left many people who didn't have any support having to rely on from food parcels to other services to be provided to actually help them carry that out. And letters were being sent out, letters were late, letters never got to people, people didn't understand it. And this was across the whole of the leukemia group. So we had very little time to implement, implement change. And develop new working methods and practices, and learn the new systems and the IT, the same as everybody else did. And the challenge was really to upskill an existing workforce that were geared up for working towards a lot of in-person support, but most importantly was to upskill patients, so that patients had the capabilities to maintain contact with us. And of course, we've also got a lot of conventional areas of support where we have members or patients that we're not a membership organisation. We have our patients that we support through conventional means, be it telephone, be it through email, through mail, and there was some face-to-face involved in that, but we've extended a lot of those resources. And with the comms team, they've been able to work very closely to try and reach those that aren't particularly savvy or can't get involved in digital activity. But still, there's a significant proportion of people that we're not meeting or we're not reaching. Although activities increased because of obviously the demands on services, both Leah and Marianne pointed out, as we all know, with the changing picture, every time there's a government announcement, all of a sudden we're flooded with inquiries from confused, worried patients, but not all. And that's why I just put a question mark on that at the moment. I'm just going to run through things, but give you an idea of the scale of things. So from April 2020 through to June 2021, that's a 15-month period when effectively all of the patients, when shielding was in place. And one of the problems we also had was because we support not just CLL patients, CML patients, AML patients, ALL patients, everybody's got different levels of risk. And at that point as well, there was a lot of debate as who's at more risk than, what can we do, what can't we do? So we also have to broaden, we've got quite a broad range of support groups. But what going digital did enable us to do was a lot of the rarer groups that we support, they're quite hard to sustain in face-to-face meetings when you have a very, very rare group. So we've been able to reach more of those groups. But to give you an idea of the scale, over that period of 15 months, the regionals have converted services to digital and have managed to provide 326 individual support group meetings that reach across the different leukemias and across the different topics. Obviously, the main one has always had a focus of COVID, as we know. And over that period, reached about 3,195 individual attendees. And during that same period, we, having converted all of our events in terms of in-person events to webinar, we managed to hold 39 webinars over that period. The majority, the first year, were always very COVID related during all of that uncertainty. But we had, one of the problems, we've had to replicate a lot of the different the webinars so that they're relevant for the different disease conditions or the different types of leukemia as things have moved on and things become a little bit more specific as the data started to come through from trials. So I suppose just the thing to note there, that there's been a considerable increase in attendance rates and reach with switching over to digital use. But it's been difficult. It's been difficult for everybody. You know, I'm sure everybody agree. Learning on the job. Everybody's had to start from scratch. The organisational team have had to implement tools and processes, and then we've all had to take it on board, and we've all had to learn on the job. And you know, part of the problem was actually as well from our point of view, everything being back to back, trying to keep pace with the demand, and also just the speed of everything. So what I was going to, I had it on my slide first actually. Opportunities was greater collaboration and greater connection between patient charities and clinical communities. It was essential to maximize reach and ensure clarity, make sure we can get the information that we need. And that's an essential part of what's needed to be able to get the information when none is really available. And sorry if I'm stumbling on my talk at the moment. I mean, essentially in the UK, very similar to in Holland, we have a very strong relationship with our clinical communities. We work very closely with them. As you'll see during the event, you know, many UK doctors, Renata and Anna, have already been on and have very collaborative relationships. But it has actually enabled us to strengthen our communication lines with HCP, you know, with healthcare professionals, to make sure we can keep our patients informed. And there's been a massive value and a feedback there for the doctors in actually being able to use the methodology of participating in all of these webinars, all of these support groups, as one of the only ways they've been able to provide feedback to their patients. The other opportunity was the speed of delivering reliable information, as Marianne pointed out there. Digital conversion has enabled us to get information to people when it was needed. And part of our work to actually try and find out what was needed was, Renata touched on that a little bit earlier today, on the collaborative study with CLL Support and UK CLL Forum, for example, in CLL, which was a moving survey that constantly gave us information. So we got a lot of understanding of what was happening on the ground for patients. I mean, essentially the opportunity in terms of, we've ended up reaching more for less. And I think another thing that hasn't been mentioned is digital conversion also enables creation of enduring content. It's a little bit like this conference. We might not have many people live at the moment, but the content is then going to be on the platform for a while, and it's going to continue to empower. Hopefully other people will then visit the sessions. And I think that's another one of the pluses. Also, you know, webinars as well help with a much wider outreach and have helped us because we stream live as well, not just through Zoom, stream live to Facebook. And then obviously when the webinar, when the videos go up, it's massively multiplied those figures that we were actually showing there. And from an ongoing point of view, that's now definitely built into our future plans. I mean, in conclusion, it's been a success for us. Yeah. But possibly only because we had the resource. Everybody's had to change. More patients are now being supported by the charity than they were before, and we're reaching more. Whether that's because we've been approached by a lot more, whether that's because digital access has helped, collaborations have helped, or because more have been in distress and they haven't been able to reach out to their normal support areas. We need to do a bit more work to explore that. The webinars and the virtual support groups that we converted to, they continue at the same high frequency as they did in the first year during the panic stages, but now a lot more diverse. We're focusing on more traditional elements, or more, standard elements of living with your diagnosis and living with your condition. We're able to mine into health and wellbeing strategies now becoming more important. Patients have been isolated and locked down for a long time, so we need to actually change the focus of support. So now that this is in place, we're able to deliver more easily a much broader range of traditional support. But what has come out of this, and we heard this from Jan, and we've heard many people mention it, in-person peer support, in-person support is probably one of the most important aspects of what we do. And, at the moment, there is a massive crying out need for this again, to be able to, just that cup of tea, as Jan mentioned, just as Jana reiterated. So I think, as Marianne said, it's definitely built into Leukemia Care's plans moving forward to run both in-person and virtual events alongside each other when safety does allow. I haven't given you a lot of information in this because I realized there wasn't a lot of time, and I haven't really got much more to say. I was going to put lots of nice comments from patients because I had pages of them and I didn't have time to stick those up when I was, but the feedback from patients as to how important this service has been to them has been, we've never had feedback like it. I think it's been life-saving for a lot of people because they've had no other communication channels and they've not been able to get regular information. But thank you very much for listening.
That's great, Nick. Thank you very much for that presentation. It was good to hear all about Leukemia Care. I want to thank Peter and Leah and Mariana for the wonderful presentations too, which leads us to the questions and answers. Just to say how this is going to work, we're going to have about 30 minutes for discussion. I said it's great to see questions coming in from participants, and I encourage the people watching to send in more questions so that we can open up this discussion. But what I will do is I have a few questions that I've done up, and just to say, I've seen from the presentations that some of you mentioned collaboration with clinical-led hematology organizations and healthcare providers. This seems to vary between jurisdictions, and I suppose I'll start with Mariana. Could you elaborate a little bit more on how this process worked in your country? Muted there, Mariana.
Is it possible to get the slides the way that we see each other?
Oh, apologies. I thought the moderator would take them down.
Okay, thank you. What we did in the Netherlands or over the years is trying to collaborate more and more with the physicians, and we are able to participate in their working groups, and their working groups where discussions are held about guidelines and about studies, etc. So we can have input there. So you have already a good link with your physicians, and that link we also use to check our information that we disseminate, to get also the information. So it's really you have to build up the trust to do that. And that's what we used in this time of pandemic, to get from them all the information. What we did, at least, is have one person who was our direct contact with the hematologist, and if needed, we had more. But you don't have to, we wanted to coordinate it a bit, that you don't get a lot of information, let's say, not coordinated, and that was one thing that we found important to do.
Yeah,
so it's over the years that you develop these things.
I have the benefit that when I'm moderating this, and also our organisation CLL Ireland, that I actually envy the countries that have good collaborative relationships with haematologists. And we felt at a loss really to get information. We had the benefit that the UK is right beside, so we had top class information to give to our patient community. I suppose if I ask Leah in Israel, if I can kind of put the same question, that pre-COVID and maybe with the COVID pandemic ongoing, how did the interaction with the clinical haematologists and getting information for your patient community?
First of all, I want to tell you, Heitel, that it didn't start yesterday. It took a long time to get this collaboration, and not all the time. At the beginning, it wasn't so easy. And now I think after so many years that we exist and work, we have very good, very close collaboration. Also, it depends who are the doctors who are in the head of the associations, etc. I think that during the years they learned that they can be helped by us. They can rely on us, like the project of the transportation, which was very important for them as well, even more than for us. And they trusted us with it. So it became a two sides collaboration, but it takes time. And a lot of time invested in it as well.
Yeah, I would say that we're at our infancy in that situation at the moment, but we're hopeful. We're hopeful. There's a few things happening at the moment. And Peter, in Canada, what's the situation in Canada? Have you muted, Peter? Sorry.
Thank you. I would say we have a limited number of collaborations. However, they're very good relationships, very strong relationships, and we appreciate those. In fact, with this past campaign, in many cases, it was the medical community who was our spokespeople. All that said, I go to my hematologist and I'm not sure he even knows we exist. So, so there is a long way to go. And frankly, that's one of our challenges that we've taken on for the year ahead, to build a better relationship.
I suppose when you say that about going to a hematologist, and he may not know maybe a lot about CLL, that's really the cornerstone of advocacy. That's why we try and, as patient advocate organisations, is inform the patient community so that they nearly become the foot soldiers. So when they're going to their GPs or whatever,
Exactly.
So I suppose Nick, would you like to say a few words? I know, I'm very envious of the UK with relationships, and we did see that through the sessions. With Renata and
yeah, we've got I totally mirror what Leah and Marianne have said. It's a very long process, but it has to start somewhere, and it's also a bit of a chicken and egg, isn't it? Because you've got to gain the trust and evidence that you have capabilities before you will get any referral or any engagement with the clinical community. So you need to sort and find out who are the champions in shared decision making, who are the champions in advocating for those patients. And sometimes these people initiate themselves. So in CLL in the UK, we were very fortunate, with Terry Hamlin in 20 years ago, deciding when he would form the UK CLL Forum with Professor Danny Kotowski, they encouraged patient involvement in that. And they've grown as two charities, grown alongside of each other. But there are ways to approach us that. And I think when we're looking about engaging with not just haematologists, I know healthcare is delivered differently in different countries, but clinical nurse specialists are really important, and GPs are really important. So a good place to start is identifying who are the champions, who are the most supportive people to you, and try and bring them together into advisory groups. If you've then got advisory groups, you can mobilize them as a group. Not only that, though, they can evidence for you what they see as their priority. So it's always a bit of a quid pro quo, I find, because that's what I do for my job. You know, my job is I'm always asking hematologists, clinical nurse specialists, GPs to do things. Yeah. And getting, you know, by building up that relationship, you can then get more involved in other activities with them. And inevitably, it's how you can also support them, not just supporting your patients. That's what I meant by a bit of quid pro quo. But a good place to start is by making sure you've developed some local, you know, your own advisory groups that you've started by selecting those in your community that might be most likely to champion. I think that's not what I can say. It's a difficult one because it's a very long, slow, organic process.
Yeah.
But eventually you get there. Like I know Hematon, for example, also, you know, in the UK now, in CLL, we've got a very strong relationship, and it's written now into the new guidelines that, you know, following the first consultation and counselling, that patients, as part of that diagnosis process, must be referred to. But then it's guidelines. You know, not all doctors listen to guidelines. But it just takes time. It's chipping away at it.
It just shows how important the likes of our Horizons conference is that we can get to compare the different organisations. And I found myself actually taking notes and finding actually that's a good idea. I
wouldn't like to fill Anna's shoes inbox, but you know. And one of our other lovely speakers from Canada are also on the same committee at IWCLL, and they have got, you know, they've formed a global development community, and you know that they're champions in shared decision making.
Yeah.
And I know that they're very, you know, very much, as Anna said, that she also works in champion resources in Tanzania. So I think that's the thing as well, is try and find clinical specialists or HCPs that are champions of your own cause, and then build a relationship.
That's great, Nick. Listen, I'm delighted to have some questions in from the participants, and I'll just remind participants to keep sending your questions in to keep this conversation going. But a compliment for all of you. Those were terrific presentations. Just wondering if anyone has a sense of how many patients did not connect because of lack of knowledge on using digital platforms. And I think that's a really good question, because how do you survey the patients then? You know, that's to find out. So I don't know if Mariana, do you want to pass a comment on that? Or?
Yeah, I think we've been doing. Yeah, I think we've been worrying about some of the groups in the country that you don't reach. Some ethnic groups that are hard to reach, and that's one of our actions in the coming years. And also people who have low health capabilities. They don't understand what their doctor says. So we've developed some materials to reach them. Let's say pictures that nurses can use to help explain the diseases. And that's one of the things that we really want to pursue more. So we're always aware that we only reach certain groups, and that we must do more to reach a lot wider audience, and that's in all the different diseases, and especially in the acute diseases it's even more difficult because these people don't stay long, whereas the chronic, you get a lot of people who stay long in your organization. What I would like to say about the previous subject is we have good contact, but you have to find in your organization people who have enough time or enough background to have these good contacts also scientifically, and also train in your organization your followers, that when you at a certain moment stop the work, that someone can take over.
Yeah, I suppose, Peter, would you like to pass a comment on that?
I think all I would say is it's important to keep in mind, I think, when you're trying to reach people, and, you know, we have the same issue that everyone has, but is who are you really trying to reach? Who is the audience you're trying to reach? If you're not going to be able to reach a certain demographic digitally because, you know, they're just not in tune or what reason, well, the primary caregiver becomes really important to reach those people with the message.
Yeah, the wider family. So I suppose it's moving into the printed.
Leah has her hand up.
Leah, I'm sorry, Leah, I didn't see her hand up there.
Okay. What I wanted to add, there are two things. A lot of older people in this pandemic learned to use the computers because for sometimes they couldn't get in touch with their families. So it was important, and I know a lot of people, and I have a lot of friends that their grandchildren come in and they teach them, and even I have to say myself that my grandson came in and he taught me at the beginning of the pandemic how the Zoom and everything. The second thing is we shouldn't forget the telephone, because everybody can use the telephone. This is very old technique. And I think that this program that we have, the circles, the peer-to-peer connection, is also a way to bring the knowledge to people, and people that connect by phone, you can help them or stay on the phone with them.
Yeah, it's a very good point. Very good point. Another question, and actually a lot of the questions coming in about the digital space. So I'll stay on that subject. I've a few questions here, but I don't want to move away from it, and I want to read these questions out to you. Very interesting that you are managing to organise 326 support groups. So I think that was that mix, or
that was individual meetings.
Yeah, individual meetings
over the period of 15 months. So that's how many meetings there've been, but that's spread across all of the lots of different cancer sites. So that might be a broad blood cancer group, that might be a rare individual cancer group, that might be a local group, that might be a regional group. We've extended the reach because of digital. They were just purely local. Now because there are no borders. Yeah.
Well, the other part of that question was, I would like to know a bit more on how the patients were informed about them, and was there any help for the participants to join these meetings? So there's a good one.
I suppose an answer to that is that we had an established network of in-person meetings before. So the regional coordinators were responsible for managing their regions and their support groups. They already had conventional contacts. Now, a lot of that contact wasn't necessarily digital contact. They might have had phone contacts. So we have the data, our database, obviously, with permissions. So it's GDPR relevant, and the permissions that are sought from those that we're in contact with hopefully identify what their preferred communication methods are. So before switchover, we already had a network. The network has grown, and the capabilities of digital connection has made more people come from all over. People, if you had a local support group now with the digital connection, you can have people come from the other end of the country to drop into a local support group. So it's definitely increased access from that point of view. And because we already had regionals who had a one-to-one connection with all of the members in a local support group, they were able to help switch them over. And that was part of trying to upskill, existing people. But a lot of people haven't felt comfortable with it. So as a charity, we've got other resources. We have one-to-one buddy schemes. We have a telephone support system. Yeah, and of course we also use the post. Gail, who works out of is based at the office, is there with that franking machine, and that franking machine is always busy. Yeah, so it's really important to keep, as Marianne said, keeping conventional communication lines open. Sorry, it was Leah said that. Apologies.
Peter, I suppose leading on from that, have you found that your organisation, like your presentation on the campaign for the World Leukemia Day and the immunity protects our community, but do you find that your organisation is campaigning more during COVID for access like treatments, and especially to make sure that our patients have access to vaccination, or literally that the patient voice is heard? I know it's kind of leading on to what we've discussed, but
yeah, well, obviously we raised awareness with our One campaign. We also petitioned the political side early in COVID with about think it was about 30 different cancer groups with related issues and we think it did make a difference. It sped up the ability of cancer patients to get vaccine. I can't remember exactly, you know, things move so quickly, can't remember what the campaign was at the time. But at this stage, it's getting, for us, it's getting information out to people. So we're certainly working on that with something we've expanded and enhanced our newsletter, for instance, with the latest information for people, and that's been helpful, and we've had reaction.
Have you found more patients maybe contacting your organization?
You know what, I wouldn't say anything, any spectacular drive of new patients, that's for sure. And I know our website, well, we had an initial jump when we did the campaign. We had jumped sixfold or something like that in terms of people coming to the website. I was hopeful in many other campaigns that you get a bump and suddenly your base is about 20% more traffic. I can't say we experienced that.
Yeah, we sometimes find when you're saying CLL, that people don't relate the letter CLL to a leukemia or to a blood cancer. So right. It's, you know, so that can be difficult to spread awareness. I know that many people that that when we were campaigning here in Ireland, they'd only heard about CLL for the very first time. You know, that's what I suppose it's like the patient's been diagnosed. Mariana, have you found that your campaigning may be harder compared to pre-COVID? I know as advocates, we're always campaigning for access to clinical trials. And have you found that during the COVID pandemic, this has increased? Or
I think not really. A lot of the work that we do as advocates with, let's say, healthcare professionals or the Ministry of Health and that kind of things are all now in meetings online, and people will know to find us. And for me, I think it's good that we have that, but because it's less travel time, even in a small country, so you can do more things. And I think it's you do some different things. You have to adapt to what people need, and that's what we're trying to do. But I think you can't go on campaigning. What we also seen in the website that you sometimes have other people that you had before in the meeting. So I think we have to learn how to have these both groups in the future linked to the organization. And we got quite some people via the website where we also published our webinars. And when people had gone to a webinar, they could press a button and get more involved. And that helped.
Yeah, I suppose I had taken a note down during your presentation, and when you said that you were one of the first groups to get access to the vaccination, it shows that you were doing something right. You know, that's you know, that's it meant that the message was actually getting across. So you had probably made the right contacts pre-COVID. I suppose at that point about it's a slow process to get them contacts made, but you maybe had a strong organization beforehand. Okay, so I think that we're out of time, or we're running out of time. So I'll just yeah, sorry. Okay, so look, at this stage, there's going to be a 5-minute technical break. I want to thank actually all of you for the presentations. Actually, that's probably the most important, and for the discussion. As I said to you, it helps my organization to hear everything that you're doing right in your countries. I want to thank you for participation during the session and for generously sharing your insight with us, and encourage the panel to continue your restless fight for CLL patients in your country. Now, at this stage, we're going to have a 5-minute technical break, and following that, we were going to have the Best Poster award session, but we've actually decided to have that go on for another 24 hours. And I want to let you know as well that invite you all to the light-hearted and interactive entertainment show with a magician, Darren Delaney. You cannot miss this magic show. It's probably the first CLL branded magic show ever. And after a full day of scientific and advocacy.
Michael, can I just say something? Felice is going to come on and give his session, but he's so he can explain what's going to happen and what the prizes are. That's what's going to come up next.
Okay,
we're just delaying the actual announcement of who the winner is. Sorry to dive in.
No, I'm glad you did, actually.
That's why Felice is waiting in the wings.
Okay, Felice. So we'd like to welcome Felice just to explain about the best poster session. So Felice, if you're there.
Yes, I am here, but the technician, please start my screen.
Oh, okay,
Yeah,
okay, no problem.
break,
Okay,
yeah.
so we're going to take a 5-minute technical break, and then we'll come back for Felice. So I'll just ask everyone just to stay put. Thank you.